Thanks, Jeremy. So I'm Matt McEwen with Imagine360. We are the health plan administrator. I'm based in Dallas, Texas. I've been with the organization for 25 years, so glad to be here. I've been working with National Council for a couple of years now, really kind of building this program. Today, we're going to talk about healthcare on the medical side. Now, there were two previous sessions that all make up this health plan. The first session was understanding what a captive program is. And the second session was around pharmacy. Okay. The captive is built really as the glue, the financing glue to make part of these programs work. Okay. Group purchasing power, renewal stabilization with the goal of driving lower healthcare costs through more creative type approaches to healthcare. All right. The second session was around pharmacy, which is a growing healthcare expense that will soon outpace the medical side. And that organization, Lavinity, talked through creative strategies to save money through transparency and the way that drugs are procured and purchased. All right. All that saves the employees money and saves you as the organization money. Today, our focus is around medical, the other big rock in the jar that drives healthcare costs. All right. So today we're going to talk through kind of quickly what nonprofit organizations face. Nonprofit is a large vertical for us within this industry. Then I'm going to spend some time talking through what's driving the cost on the medical side regarding healthcare. Okay. Most of us know that things just seem off, the pricing, the billing, the payments. We just don't know why. And I'm going to kind of talk through today some of the why. And then we're going to dive into the solutions we're offering through the captive National Council program that will reduce your costs, will stabilize your renewals, and enable your employees to be able to afford the healthcare, as well as help your organizations grow and meet other objectives within your mission. So off we go. This is kind of our mantra, right? And really for all organizations involved with National Council is that we believe that companies and their employees deserve to pay less for healthcare and have quality healthcare. And that's what we've been driving for the past 20 years. This is not entirely encompassing, but on the left-hand box, and there's a lot of words in this slide, what are the current challenges that National Council members face? And that is the obvious: medical and pharmacy costs continue to rise. Whether you're under a fully insured program, self-funded or partially self-insured program, costs continue to go up. And we're addressing all those points today. Funding, right? Especially with the current administration, where will the money come from both the government as well as donors and organizations to continue to fund the mission, right, of what your organizations do. Many nonprofits aren't sitting on giant bank accounts, and they don't have the ability to absorb increases. In many cases, really do not want to cost shift back to the plan members, who are also are working hard for their paychecks. Okay. The cost increases are, again, pulling money away from the objective of your organization. And then overall, the obvious statement here is your employees and their family members are really struggling, not only to afford their payroll contributions that come out of their paychecks to fund their portion of healthcare, they're struggling to afford their deductibles and coinsurance. And we're going to address those challenges today. So the outcome is to reduce costs. We're going to stabilize renewals, find a way to address these creative programs, save 20 to 30% of your spend, and then reinvest that to some degree, not only in your organization, but also to your employees. Offer richer benefits, reduce payroll contributions. And then the reason to act now is healthcare costs are not going down, right? Your employees will see an immediate reduction in cost, as well as you as the organization. And then, as we'll see, jumping early on to begin an education campaign for both leadership within your organization and your employees prior to your renewal. All right, so really quickly about our organization. You probably did not know who Imagine360 is. We are a replacement for big insurance. So Blue Cross, United, Cigna, Aetna, also known as BUCA. We're a pretty well-sized organization. About 1,600 employees work for us. We are nationwide. We have over 1,000 plus clients that have gone down this journey of challenging healthcare, finding creative strategies, and then making that their major medical program going forward, and in reaching those objectives we talked about earlier. We're going to talk about saving money. It's important. We're going to talk about the member experience. How do your employees experience healthcare with us? It's given us a net promoter score of 78 and a 98% member satisfaction score. It just shows that we're heavily member focused, heavily HR focused, with the objective of taking the fat out of the system. And I'm going to jump into that here right now. All right, so does this feel familiar? And this is the obvious slide here. You have C-suites within organizations that are trying to find ways to pay for healthcare. All right, you're nonprofits in most cases here, but you're not in the business of providing healthcare to your employees. You're in the business of your nonprofit's mission. Okay, but yet the C-suite's trying to find money. Human resource team, often understaffed, overworked, is also working to take care of the employees and their families. Their goal is recruitment and retention of talent, to take care of the needs of the members on a daily basis. But then ultimately you have the employee. And as I mentioned earlier, they simply cannot afford their current situation, much less what's coming down the future with potential cost shifting back to them. In many cases, those with insurance cannot pay their out-of-pocket, so they are the uninsured, insured Americans that are skipping care because their out-of-pocket expenses are more than their family budget will allow. So we're addressing all three areas today. The other piece we look around now is that, everything around us has changed as consumers. All right. I was out of town last week, and when I returned from my trip, I had a stack of Amazon packages at my doorstep. I took an Uber to and from the airport, and while I was in a hotel, I watched Netflix. Okay. But my point here is that as consumers, we're in control. Cost, typically the transparency is created market competition, and we have lots of choices on how we live our daily lives. But yet healthcare really hasn't changed at all. All right. It remains expensive, unaffordable. There's very little transparency as far as pricing. And people really just do not like dealing with insurance companies. Can't blame them. And in many markets, you're limited to 3, 4, maybe 5 options as far as where do you place your insurance each year upon renewal. This has been the same for 20 plus years. From an employer's viewpoint, you're providing healthcare to your employees, certainly as in benevolence, being paternalistic, but you need to do so because otherwise your employees will leave you and go somewhere else that has health insurance. But on the right-hand side of the screen, this is what things should look like. You're the employer. You're financing the majority of healthcare for employees. Okay. You should have a seat at the table with the insurance company, the hospital systems, the drug companies, right? All working collaboratively to provide healthcare. But the reality is you're not at the table. I often say that there's a big party being thrown between insurance, hospital systems, drug companies. You're paying for the party. You're just not invited to attend the party, right? And the result of this, stock prices on the healthcare side around big insurance have soared over the past 13, 14 years. Big insurance companies did not become big insurance companies because they set themselves up to lose money. All right, so let's kind of dive into one challenge that employers face, regardless of whether you're fully insured or self-funded on your health plan, okay? Geography map of the United States, pretty obvious here. I'm in Texas, so let's focus on Texas, the big state at the bottom, okay? What this map's showing us is just on average how much hospitals mark up their services over their actual costs. So you can see in Texas, 683%. So that means that on average in the state, the cost of services being billed by hospitals is 683% over their cost. All right. Florida, 732%. You can see the rest. Okay. This just simply means that most employers that use an insurance product use a PPO type product, preferred provider organization. And their major saving vehicle is the discount that's being offered through the PPO. So as you can see, the obvious statement here is that at markups of 683+%, the discounts become irrelevant. All right. If I get to set the price as a business owner, I'll give you whatever discount you want. And this is why managed care has been breaking down for the past 20 years. Another map of the United States with different percentages. This just represents simply how much more those of us with a commercial insurance card in our wallet, all right, so if you have an insurance plan, how much more your commercial insurance plan pays over what Medicare pays. So let's focus back on Texas again. What this means is that people insured pay 259% more than what Medicare pays that exact same hospital for the exact same procedure. This represents cost shifting, all right, from the healthcare systems, cost shifting onto commercial insurance plans. This is not sustainable. And these numbers go up every single year. And then what PowerPoint's not complete without a very small and confusing line chart, right? But simply saying here that the top lines represent the increases in family premiums for healthcare versus the orange line of what employees are paying through payroll contributions. And then the bottom line is representing our workers' earning and overall inflation. Healthcare is outpacing for both employers and for their employees and families, are far outpacing their wage increases. All right. And then to put that in round numbers, although wages have increased from 32,000 to 41,000 nationally on average, the number of employers offering healthcare has gone down substantially, and yet the cost of family care has gone up 4 times. Again, most of you say, yes, we know this, Matt, we get it. This is what we're addressing today, and have addressed for the past 2 sessions through the captive program, the creative pharmacy approach, and today we're talking about medical. All right, so what Imagine360 is delivering, and I'm going to start unpacking this in multiple areas. We are a replacement for big insurance company, okay? And our goal is to deliver a better member experience, the concierge services, less confusing with one phone number to call for everything, transparent reporting, transparent claims, creative pharmacy strategies, et cetera, virtual services. But we are the one-stop shop. So some people will ask, well, how does Imagine360 work with my Blue Cross Blue Shield program? It doesn't. Imagine360 needs to replace your big insurance program. All right. Again, we have over 1,000 clients. You would know many of our clients' names. And every client that has gone down this journey with us has said, you know what, we're tired of status quo. Let's do things differently. And let's take a stab at healthcare to accomplish the goals we talked about earlier. All right, so let's start phase 1 here. I just talked through the broken system on the medical side. Let's talk about how do we reduce the healthcare cost. As we say this, part of the National Council's offering is to provide employees and employers options. We're going to talk about what it says RBP, what is reference-based pricing, how does it work? I'm sure there'll be questions from that. But then we're also delivering the ability to stick with status quo, meaning that at Imagine360 as an administrator, we can either offer reference-based pricing that I will go into, a national carrier network, or a combination of both and giving employees the option. Okay. So let's break down what reference-based pricing is. First of all, I want to talk through the fact that as we move into a creative approach on the medical side, we're not looking to challenge doctors. We're not looking to limit access to doctors. Okay. We're providing network solutions for doctors. But at the end of the day, the way the National Council plan is set up is that we have to forget what we've been taught for the past 35 years. Is my doctor in network or out of network? Particularly as it relates to reference-based pricing, it doesn't matter. All right, employees are free to go wherever they want to go. So very broad access point. But now let's jump in on the medical side. This is kind of where the rubber meets the road and how this program works as it relates to facility care. When I say facility, what I mean is inpatient, outpatient services, emergency room, dialysis, imaging, big brick and mortar type buildings. This is where we're doing things differently here. Okay. So as we say this, how is this set up? Well, every single hospital in every city in every state maintains what's called a charge master. That's their menu, their list of their services and their medical products that they basically sell or deliver for time of care. The problem with the charge master is that there's no regulation. All right, outside of Maryland, there's no regulation in any state other than Maryland, meaning two hospitals 2 miles from each other can charge whatever they want to charge for a service, whether it be a CT scan, a Tylenol, a stent, or knee implant, right? There's no regulation on that. So let's just in this example here, let's just call this a CT scan. Hospital charges $5,000. Pie in the sky price, no regulation. Your current methodology today through your big insurance programs is to get a discount through your PPO network. Let's call this half off. You got a 50% discount for the CT scan. So the cost goes from $5,000 to $2,500. Okay. Whether the employee needs to pay that through their out of pocket, whether the employer pays it, the insurance company, somebody's paying $2,500. The situation, though, is that CT scan they charge $5,000 for only costs $250 to perform. Right? Medicare would pay that hospital about $280 for that CT scan. The way reference-based pricing works, and we've done this now for 20 years, is rather than top down, we're working bottom up. So we just set metrics to say, we want to pay the hospital fairly. We want them to be profitable. We just need to get away from this top-down approach. So we structure a bottom-up approach. So we say, what is the actual cost for service? And we add a 12% margin of profit. What would Medicare pay? We tack on 20%. And we say, which one of those two is higher? And that's what we pay. Again, fair and reasonable to the hospital. We want them to be profitable. So in this situation here, we would have paid about $336. Hospital's making a profit. Now let's take this back to the employee, though. Let's say that they have not met their deductible. They've not met their out-of-pocket. They're going to pay $336 versus $2,500. And how many hours would that employee have to work to pay $2,100 and call it $50 additional towards their out-of-pocket expense? In many cases, it's 200 plus hours of work just to pay their out-of-pocket expense. And we're driving that to their bottom line, driving that to your bottom line. I'm sure there'll be questions around this. Jeremy, do I have any questions so far?
No questions so far, but folks, feel free to put your questions in the Q&A chat. We'll have time throughout at the end, and also we may have time for folks to actually raise their hand and come off mute if we need to.
Great. I know you're drinking out of a fire hose with me right now, so I can understand that, and I'm kind of sympathetic for you as well. And this just makes the case of what I've just said. Okay, back to the CT scan. All right. Under traditional insurance plans on the left-hand side, this employee who makes $60,000 a year, let's say they have an $8,000 family deductible, just their out-of-pocket alone is going to equal 57% of their monthly salary, as compared to with our structure about 4%. We're making healthcare affordable, again, for people to actually obtain healthcare.
Hey, Matt, questions coming in, I guess, sort of parts here. How are those prices I mean, this sort of questions are on negotiation. You sort of spoke to the insurance companies negotiating with the hospitals or the providers, and that's sort of where you get to PPO. But how does that negotiation work? And is this for every service? It sounds like there may be some exceptions, but can you speak to that?
Yeah, great question. Let's first take the part of insurance company negotiations, and I'll get into how we operate. What's happening here in Dallas, Texas, for example, is yesterday, our large teaching hospital, UT Southwestern, officially terminated their contract with one of the big insurance companies, one of the big nonprofit insurance companies, won't name their name. That was active yesterday. That's negatively impacting employees, but guess what's going to happen? They're going to find a way to negotiate the terms. Give them 7 days, 2 weeks from now, UT Southwestern will become part of that big insurance company's network again. Well, guess what just happened to the local employers here in Dallas and their employees? Their costs just went up. Right? Those negotiations are not to bring costs down. It's the hospital saying we want more. Okay. The way our program is set up is that in most cases, we're not calling ahead to negotiate. To be technical, we're using the power given to employers under captive programs under ERISA, the federal law, to set fair and reasonable pricing. And so on the backside, in a few occasions, on the back end of services being rendered, we have to negotiate on the back end of a claim, whether we negotiate or we just stand firm with our pricing. And as I'll talk about here in a minute today, but by no means under our structure does your employee ever owe more money. By no means. All right. So in this example here, if your employee had paid $229, in the rare instance where if that hospital did come back and say, we don't like what we were paid, they cannot negatively impact your employee, nor will your employee pay more than $229. Okay. So we're not negotiating on a claim by claim basis ahead of time. We're using the power of ERISA. We state the plan payments clearly in our language with the hospitals. But should the hospital push back pre-service or post-service, we have a solution and a formula to address that, protecting your employee and protecting your plan. Those situations are very rare, but when they do happen, we have a solid approach to that. And again, we've done this for 20 years. We process millions of claims every year. But all that we're talking about in this structure here is only for facilities. So if you look at your claims utilization, let's just say you had 1,000 claims paid in a year. Okay, 900 of those claims are going to be doctors. We're not looking to challenge that part. 100 of those claims will be hospitals. That's the part we're tackling. But that's where the money is that's where the plans are overspending dramatically. Not on doctors, they're overspending on hospitals. So we're addressing the big rock in the jar that drives the most cost, but the least amount of frequency. So let's talk about the National Council program as it relates to the member experience. And again, I recognize today we're flying at about 100,000 feet. For those organizations that are on the call today that are interested, we definitely need to go deeper and deeper and deeper in future conversations. But let's talk at a high level what the members experience. Talked about earlier, our 1,600 employees that are being driven, that are driving this program. We're offering full clinical teams to help employees with lifestyle coaching, their chronic conditions, their catastrophic conditions, transition of care. We provide billing support. I'm going to talk here in a minute about providing guidance for employees that want it. But all this is driven through one number to call. We see a lot of healthcare plans out there that are offering creative strategies, and they're using multiple vendors to do so. And it's confusing to your employees because you have 1, 2, 3, 4, 5, 6 different vendors that are engaging in creative strategies, but to your employee, it looks like NASCAR, right? Which logo, which number do I call? Through Imagine360, through the National Council plan, we're driving everything through one number, one website, one app, okay? But part of what we're driving and making available to employees, but not requiring them, is our concierge navigation services, right? This is not required for employees to use it, but we certainly want to make it available to them, okay? This navigation team, concierge team, will help speak to your doctors before your appointments. They'll help schedule appointments. They'll do research for you and provide recommendations based off of quality, access, and cost, okay? And we're just really kind of hand-holding the experience. So let's contrast this to your current plan today. So you have a 33-year-old employee. I'm a male. I'll pick on my gender, right? That 33-year-old male, the last time he saw a doctor was his high school sports physical, right? Now life's happened. He needs to find a doctor, right? Under your current structure, he's going to go to a website, BlueCrossBlueShield.com, Aetna.com, what have you. He's going to put a zip code in, and that web search is going to produce about 95 doctor options in a zip code. And that employee just became overwhelmed, okay? Doesn't show when that doctor can see him, right? Doesn't show are they taking new patients. It just says, here are the doctors in our network in your zip code, right? And guess what? They can do that with us, or they can call us, or message us, or chat with us, okay? We're going to ask your member, are you looking for a provider close to your work, close to home? What's happening? Why are you looking for a provider, right? Are there any language barriers? And so we're going to ask the member for a set of criteria and what and why they're looking, okay? And once we have that, we're going to reach back out to your employee, not with 30 options. We're going to give them 3 or 4. And if we want 30, we'll give them 30, but typically 3 or 4. And with that, we're showing them the quality score of that provider, what their out-of-pocket cost estimate is. But what I like the most is we're showing your employee when that provider can see them. All right. I used this myself a few years ago to find a cardiologist. And I just said, I'll take the second option at 8:45 on a Thursday morning. And they made the appointment for me. Again, we're not requiring employees to use this. This is not a gatekeeper. We just want to make this available to them. Just a real quick example where we actually scheduled an appointment for somebody that needed to find an orthopedic. Right? They called us on a Monday. We had them set up on a Tuesday last year. And this is a quick snapshot of what this can look like. Again, hand-holding in healthcare and just making healthcare easy for the employees. Another big piece through National Council, and this might be new to a lot of you, quite frankly, most of you, is a service that we have that we call Upland Advocacy. The name's not important. And in long story short, here's how this program can really help your employees. Okay. Every single hospital, both for-profit and nonprofit, are required to set money aside to help middle to low-income Americans with their medical expenses. Whether it's their out-of-pocket expense through their insurance plan, whether they're underinsured on a limited plan, or they're uninsured completely, okay? The hospitals are required to set money aside. So what's happening is hospitals are setting the money aside. They just don't talk about it. And they're not calling your employee saying, I know you owe $4,000 for your hospital stay. Here, we can give you some money for this. They're not doing that, okay? So we started what's called Upland Advocacy. We own this solution that when we process a medical expense as a result of a hospital claim, so inpatient, outpatient, emergency room, we initiate with your employee. We complete the majority of the paperwork for your employee. The employee needs to sign the form, and then we secure money to help your employee with their out-of-pocket expense. Whether it's their entire deductible coinsurance or a portion of it. It's hospital-based and income-based, okay? But we do this to put money back in the employee's pocket. We typically charge for this service separately, but part of National Council is we're including this in all of our plans. In the nonprofit space, 75% of your employees will qualify, all right? Just a quick example of California. And this is very similar in most states within range. And again, a small sampling of hospitals there. But let's just take a look here at Children's Hospital of LA. Household making $103,000 or under, we can get full funding for their out-of-pocket expense. Some hospitals at $65,000, okay? Whether it's full funding or at least partial funding, again, it's income-based. We're securing money that's sitting out there that's not being utilized and putting that money back in your employee's pocket. So Goodwill of Texas is a client of ours, obviously nonprofit. They had an employee that makes $21 an hour. And just a few months ago, we secured the entire $3,500 that she owed through her out-of-pocket expense as a result of her employer's plan design, right? So we got $3,500 of funding. She owed nothing. And then to take that back into what I said earlier, she would have had to work 220 hours after tax to pay for her out-of-pocket expense. We gave her a month of her life to her, just to the Upland program. And again, this is embedded in all of National Council's captive health programs. We also offer an integrated full service virtual suite of services. Many of you are familiar with telemedicine. In most cases, people know it as I call when I have a sinus infection, which is urgent care, which is fine, or pink eye or flu, what have you. We've expanded our virtual services though to say, you know what, we can do the same thing with direct primary care, and also do the same thing with mental health. Okay, I had a wellness exam yesterday. I do have a doctor relationship, but I could have just as easily had the labs gone straight to the lab organization through the direct primary care and skip time and cost. Okay, on behavioral health. Many of us know that accessing mental health therapy is number one, challenging, and number two, a long wait to get in, and number three is expensive because most mental health therapists do not file for insurance. Okay. Through this, members can access mental health therapy virtually, unlimited, with one therapist. There will be a one-on-one relationship that they can select that therapist, or if not satisfied, choose another therapist. All this is being driven through NatCom, in many cases at no cost to the members. All right. This is also fully integrated. So if your employees if they call our concierge service, and let's say they're calling in to find a doctor or an urgent care center, and again, they have a sinus infection, we will direct them or give them the option to say, we can get this done right now through the virtual service and probably at no cost to you, depending on your plan is on. Okay. Again, embedded, driven through the National Council captive program. I'm going to move through these next slides pretty quickly. We'll open up for questions here. We're going to engage members all throughout. We're going to engage the HR team, engage members all throughout the journey. As you can imagine, if you move from a big insurance program to an Imagine360 approach, where things are different, a little bit different, things are more creative, we want to educate the employees all throughout the plan year. Big thing here is selling to them the win. How are they winning from this approach, right? And our team knows how to have that conversation with them. But we're coming alongside you, your HR team, and messaging the when, the how, the what to the employees, again, all throughout the year. And again, driven through one site to visit. One piece to this, and I know many employers here on this call today are what's called fully insured or fully funded. And you've probably seen it, very limited data to no data, right? Since we are a third-party administrator, your data is your data, meaning that we're here to provide data for you as an employer at a very detailed level where we can all make educated decisions together on what things look like going forward, future predictive cost analytics. But we're using data to really get to the bottom of what's driving cost, where are we winning, where are we losing, and where can we improve. All right. Any questions so far? I know there's a few in the Q&A.
Yeah, Matt. No, I think you're about to probably touch on where a lot of the questions are around is just, hey, but what happens if, you know, that comes up? So yeah, I think keep going.
Perfect timing. All right. So we've talked about this thing called reference-based pricing. We've talked about the advocacy program. We talked about Upland Advocacy that finds the money. What's the catch? All right. So the catch is, if it's such a thing as a catch, is that clearly we're not playing the hospital's game. All right. We're using the power of ERISA to set reasonable reimbursement limits. I mean, you have the right to do that, and we have the right to do that. But in some instances, the hospital is going to say, we don't like this payment. We want more. And they might send your employee or their family member a bill. It's called a balance bill. All right. I will say nationally, and we can run this by in your very specific marketplace, in your areas of where your employees seek care. Nationally, the frequency is about 5%. So if I pay 100 hospital claims, 5 people will get a balance bill. In some markets, it's 1. Some markets, it's 10. Okay, and we'll share that information with you just so we can all know what we're getting into. But if a balance bill happens, I want to point out something I said earlier. Your member does not owe it. All right. I also want to point out that your members are getting balance bill today, meaning their deductible, their co-insurance, their out-of-pocket, the out-of-network providers, etc. Right? They have to open their mail today, and they need to open their mail with us. And if they call us or reach out to us with a bill with questions, and we determine that, you know, Jay, you don't owe this bill, or Jane, this is not your deductible, this is not your co-insurance. What we do at that point is we take your employee out of the middle of it. We assign them a one-on-one advocate. We then handle and take over the conversations with the facility, whether it's to fight them and stand firm or to settle and negotiate. That's kind of how our secret sauce is made. But we've taken your employee out of the equation. We've protected them against any harm. And by no means, as I said earlier, do they owe any more money. Right? That's the catch. 5% of the time, the employee needs to engage with us. And if so, we step in, advocate, and protect them and get them out of the middle of it. The employee's credit will not be impacted, and they will not owe any more money, but they do have to reach out to us. This is more than you want to see here. Okay. Again, this shows the average 95% acceptance rate. We have a proven solution for the 5% where we do get pushback from providers. And again, full advocacy. Once the members called us one time with a bill or concern, If it's a balanced bill, then now we're the ones calling them, keeping them up to date with where we are, and asking the employee to notify us if they're contacted again. But your employee is protected. We've kind of perfected this process over the past 20 years. And again, this is important to understand this. And at the same time, too, as you move down this journey with us, if you're interested, we want you to fully vet this and speak to other clients that are doing this to understand this process. From an HR support perspective, and this is really important, okay, this just has a group by the name of Best Way on there. We're providing a full support team for the HR team. But most importantly also is that we're providing an HR support advocate to get the HR team out of the middle of healthcare. All right, this person will hold virtual office hours. They're our employee. Where if an employee has questions regarding their health plan, the HR team's job is just to push them to the assigned advocate. So virtual office hours is like we're working for you, and we take the workload off of the HR team. And this case study after case study after case study. All right, Stephanie Koch, HR director for Hendry Marine, actually named HR Executive of the Year by Employee Benefit News last year. Been a client of ours for many years. They took their savings from this program, right, and they opened a walk-on clinic, mobile clinic. We see that happen, not often, but it does happen. Where they perpetuate their savings and they perpetuate access to care by reinvesting back in their organizations. Another company called Marine Max. It's a boat retailer, right? About publicly traded company. We saved them $5 million the first year. Now they're larger, about 1,200 employees. They actually took the savings and made benefits richer, added additional benefits in services, but they reduced the employee's future cost of healthcare. I've seen employers take the savings and either give premium holidays to employees. I've seen them reduce the cost of single coverage, or I've seen them give away single coverage, where they're now using this for recruitment and retention. Again, status quo is going to result in increases. If we break things apart and get creative with various components, that will drive savings. It is different, slightly more of a lift up front. But once things are stabilized, meaning after 3 months when the new normal settles in, it now becomes a true benefit for employees. All right, I just said a lot. I'll stop for questions.
Thanks, Matt. And again, folks, put in your Q&A in the chat. We'll we have a good amount of time here, so we can get to plenty of them. And again, if we need to bring you off mute and you want to ask your question, that works too. One question that we want to touch on is the minimum requirements for joining. So, someone was asking, does my small company that's for profit, does that qualify? I know there's different pieces to this. Can you speak to it?
Well, as long as you're a national council member, then regardless of for-profit or non-profit, it doesn't matter. You're eligible. I think the minimum size, which is more captive driven, is 35 employees or greater.
Right. So on the for our captive vendor Pareto, I think it might be closer to 50, but I mean, Matt, you have a more accurate number there. It is something in that realm though, so it may be something that if you're sort of in that range, let's have a conversation about whether your organization would be eligible, but somewhere in that 35 to 50 perhaps employee size of covered employees, right? Employees that are participating here.
Yeah.
Let's see. Interesting question. The question is, do you have comparative statistics if you're moving from a community rated HMO plan? So, comping like any statistics on comparing people who move from different plans or different types of plans and what the impact has been? Anything you'd say to that?
We do. The HMO world is very broad. Okay, so let's define HMO in terms of separating California, like with Kaiser, as compared to HMOs in other marketplaces. Even with community rating and the cost of HMO increases, HMOs are going up dramatically last year and heading into this year in 2025. I was just in California last week. Most HMO models out there really are not driving savings through additional discounts. They're driving savings by controlling and containing the flow of care. Okay. And what we're providing is an open access plan. We're not controlling flow of care. We're not limiting choices. Typically, an HMO program will save about 18% to 20%. But many HMO programs are running in the red, so we're seeing pretty substantial increases. Very broad question, but also a broad answer as well.
One of the things that, if your organization is interested, we'll get you connected to Greg Roebuck, who serves as our broker agency for this program. And, we can start to unpack with the data that you provide, sort of what your current plan looks like, current spend, things like that. We can start to run sort of analyses of sort of what might it look like if you move into the captive.
Well, Jeremy, and with that as well, I do want to point out that, we're buying healthcare in a different theology. Put that in kind of religious terms, meaning that it's different. But we want you to have a full understanding and not just a 45-minute webinar. Part of the vetting process is there's multiple steps. Number one, we want to actually look at what's happening in your area to show you kind of what's happening from a markup perspective. Also, then what to expect from an employee's perspective on the back end. When we talk about balanced bills, I mentioned this earlier, it's real important that leadership in your organization understand you're not going to hear from the 100 people that had no problems at all. You're going to hear from the 3 that did, right? So managing those expectations is really important, and kind of collaborating together and looking at what the opportunity is. With that, we can show the savings on both medical, pharmacy, and then ultimately quoting. All right. So Jeremy, sorry, I know you.
No, that's great. I appreciate that. And folks, I'm going to sort of try and combine some questions here too that's coming in. First part of the question, then I'll ask maybe a second part. What is tangibly, what does a member insurance card look like? And speak to that dynamic that plays out between how does a provider know, when they ask that, oh, who's your insurance? And then, as an employee, what do you say? What happens when the provider's like, I don't know what that means. I don't know how that works, right? I'm sure that happens a lot.
Yeah, great. Such a good question. I wish I had a copy of the ID card. A member will have an ID card, just like they have a Blue Cross card or Aetna card. One side's medical, one side's pharmacy. This is what the provider's looking for, whether it's a doctor or the hospital. They want to know where to verify benefits. Okay. There's a QR code that explains how the plan works. So they can call us. We explain it to them. But Jeremy, to kind of go deeper on this is that, the biggest concerns members have, and it comes from what I'm going to say here, 35 years of Kool-Aid we've been taught to drink. In network, out of network. Is my provider contracted with this network or not, right? That goes for both your employees, but also for the doctor's office, okay? And so we have to communicate that to the members, that you're free to go where you want to go. In some instances, and it's not frequent, but it does happen, the front office person says, who's your insurance? And you say, Imagine360, right? And they say, we're not contracted with that insurance, right? Now, what's happening at this point is a front office person who's been taught to think this way, right? In their mind, what's happening is that if we're not contracted with an insurance plan, then we're out of network, which is not true in this case, okay? Everything's in network, but this is where their mind goes. And if we're out of network, then Jeremy's going to have a big deductible and a big out-of-pocket expense, and we're never going to get paid. That's where their mind goes, okay? This only happens a few percentage points at the time, but it's really important to address this. When that happens, here's the ideal. The ideal is your employees call us prior to their appointment. We've called the provider's office. We explain to them that they're getting paid, how they're getting paid, how much to collect from you, your copay, et cetera, and everything goes just fine. The ideal doesn't always happen. Sometimes the member's standing there when we get the phone call. My provider won't take this insurance. Yes, they will. Right? We talk to them, we explain to them. And then the worst case scenario is that provider is just hard-headed, not the provider, the front office. We then just simply use what's called a virtual payment card. We make payment right there on the spot to that provider. You'll hear more about this from your employees moving again for the first 90 days than you'll ever hear about balance billing. All right. But we have the proven solutions over 20 years to how do we effectively work this. Be proactive or being reactive, we have a solution for it.
What really strikes me about that, Matt, is, you talk a lot about the importance of employee education, right? Making sure employees know what this means for them on a day-to-day basis. And in some ways, it sounds like, oh, well, now we're asking our employees to do a lot. But the point you made earlier, like they're already doing a lot. Like health insurance is already such a big task. I mean, you need a master's degree in whatever to really navigate our systems oftentimes. And so it's not really asking them to have to do an exorbitant amount of more work that like they already have to navigate our health insurance systems. And so I think that's a key component here too, is that this is not now like, let's just push all this down to our employees kind of thing.
But well said. You basically you need 3 master's degrees. You need a master's in IT, you need a master's in health, and you need a master's in accounting to figure out the bills. And that's just for big Blue Cross, big BUCA plans, big insurance company plans. It's confusing as heck.
Yeah. Some other questions. Just sort of dancing around here. Someone's asking, hey, we're in a rural area. Any concern there on, benefit design or access to this program, things like that?
Yeah, we need to see the areas where you are. Many of our clients, employers are in rural areas or at least have employees in rural populations. We will take a look to see, number one, how many employees do you have and how many choices for hospitals do you have? So whether is it a 1 hospital town, 2 hospital town? We want to look at that and kind of make joint decisions together on how we approach things. In some cases, if you're large enough, a couple hundred employees in a small enough town, maybe it makes sense for us to engage that hospital in a contract for you, right? We don't want to disrupt the community. You need to pay less for healthcare. Hospital loves negotiating with insurance companies because they can beat up insurance companies all day long. They're not willing to beat up local employers, right? Or play hardball with them. That's probably one of the reasons why this third-party system we have today, right, is become so inefficient, is that we've disengaged the employer from the conversation. Like somebody said a while back, the question was, why is healthcare so inefficient and so expensive, right? And the executive answer to the question said, healthcare is operating exactly as it should. Efficient and inefficient and expensive because we've set up our models to say, let's turn everything over to the big insurance and let them do the negotiating for us, right? And have no seat at the table. So it's operating just like it's supposed to operate based on the current structure.
Question, another sort of more logistical question. The actual question is, does an entire organization need to switch at once, or can a few or some cohort sort of be a trial group? I know that this also, there's Greg speaks to like sort of we call it the dipping the toe in the water piece. I don't know, Matt, if you want to speak to it, or I can.
Yeah, unless you're a really large employer, you need to move the entire thing over. But remember, what we're not saying is you have to go from Blue Cross and just say we're going to go straight into reference-based pricing as it relates to medical. Remember, we can do a dual option where you can offer a traditional PPO network option using Cigna as our network with reference-based pricing, and you let the employees decide which plan do they take. Imagine360 administers the entire thing. So the concierge services we talked about, the 501(r), the funding for their out-of-pocket expense program, that also applies to both plans, okay? But the employees decided enrollment. Do I want to get creative with reference-based pricing and pay less, so lower payroll contributions, or do I want to pay more and go with the known path of big insurance PPO, right? What happens is every time, in the nonprofit space, very much so, right? Because wages are limited. Employees vote with their paycheck. 85% of your employees will elect the reference-based pricing option. 15% elected the big insurance plan option. But again, we administer both.
Again, the other way to think of this is that, as you'll see in some of our other presentations on this topic, which are on our website, dip your toe in the water, bringing on the pharmacy benefit, Livinity, wading in deeper, offering, as Matt said, the PPO or the reference-based pricing your employees can choose, or going all in and everyone's on reference-based pricing. And the cost saving opportunity, it's going to be greater, the opportunity at least. It doesn't mean that every year it's going to be, but generally the opportunity will be greater if you are fully, as an organization, all adopting the reference-based pricing. Let's see. Well, a question here about you know, whether personalized networks can be established, and maybe a way to think about this question, Matt, or at least the way I'm thinking about this is, when you've been operating for so long, you probably have hospitals and doctors' offices that have become more familiar with this thing. Do you all set up any kind of um, indication or system to say, like, these are providers that we have worked with previously, or these that we know? Yeah.
Yeah, so in two scenarios. One scenario is in some markets we have what's called high performance options. And we have that in about 18 cities throughout the United States. So for example, in Dallas, Texas, where I live, we have 7 hospital systems, but we have a preferred contract with what's called Baylor Healthcare. And we provide an incentive for employees to use Baylor under the revenue-based pricing program with no of the concerns of the pre-service pushback or post-service balance billing. Again, although rare, it eliminates that. Okay, we have those in other markets, and we have the ability to grow that. What we do not want to do is go in and say we're going to contract with every hospital, because then now we're just a PPO network. A preferred provider organization should be called an all-provider organization. Everybody's in everybody's network. There's no more value being driven through those, right? It makes sense. But yes, we also have the ability to show members if a facility is friendly with us or not friendly. Okay. And we also have a historical acceptance rate with doctors. Again, doctors are not aggressive on this piece. We're not aggressive with them. They're not aggressive with us. Okay. So we do have the ability to set up those customized type solutions, and also educate the employees on where to go.
Thanks, Matt. I know we're almost at time here, so maybe we have one more question, and then I'll wrap things up. This is sort of a bigger step back question. Again, it's really a question about, like, how is this working? Like, how is this, like, how are hospital systems accepting this? And I've heard you and Greg speak to this previously about, like, this isn't necessarily new. It is growing, though. Like, captives seem to be growing. Like, there seems to be more opportunity to join them, things like that. So I'm wondering if you might want to just, like, sort of speak to that, to the fact that, like, this isn't new, but there is a trend happening here. And again, why is it that hospitals are willing to play ball here?
Yeah, so we've been doing this for 20 years, as I said. I was always waiting for the other shoe to drop, right? Like, when is it going to get to a point where they lock the doors on us? And we've seen in various markets, we've seen threats from hospitals, but no action or very little action. And I've learned over 20 years, we respond to what the hospital does and not what they say. So we'll see some threats from time to time, with maybe 2, 3, 4% pre-service pushback, which we just have to negotiate. But I've been waiting for this trend to happen, and it really hasn't happened, Jeremy. Right? End of the day, the hospital's got to say we're a nonprofit, which, by the way, we made $300 million last year. We didn't make tax on, and we're willing to shake down an employer and their employees. Right? It just doesn't play well. So I find threats, but very little action. If there's action taken by a facility, then we have a solution for it from an access perspective. Pre-negotiate, use our virtual payment card. At the end of the day, let's just say you're in the one market with a one hospital that truly was saying, we just don't care about market perception and we're going to lock our doors. We can move you to a traditional Cigna model overnight. Right? You're not stuck on this platform for a year. It hadn't happened yet, right? But if you were the one case where it happened, we would pivot really quickly.
Appreciate that, Matt. Well, folks, thank you all for your time. Huge thank you, Matt, for your time and sharing your expertise and insight. As I mentioned, this is a part of our webinar series in which we're diving deeper into the National Council Captive Health Insurance Program. All of our webinars in that series are posted on our website, as will this one be. It is being recorded. It will be on our website. We can share it out. Slides are available, all that stuff. If you have further questions for Matt or about the program, if you're interested in, sort of to diving deeper, just to get sort of a a proposal on sort of what would this look like, please reach out to us. You can reach out to myself. You can reach out to my colleague Rocio, anyone at the National Council. We'd be happy to set that up for you. With that, I appreciate again everyone's time. Have a great rest of your day and week.
Thank you.